Hello, I'm going to talk about Subutex and Suboxone and their relationship to substance abuse and the pregnant woman. First, I'm going to start off with a little bit about these two medications. They are both approved by the FDA to treat opioid addiction. They are both considered Schedule III medications, which means there is a lower potential for abuse, whereas methadone, another medication for opioid addiction, is a Schedule II, so that means there's a higher level for abuse. The main ingredient in both these medications is buprenorphine, which is a partial opioid agonist, whereas a full agonist would cause euphoria. Buprenorphine does not. Subutex is only buprenorphine, so there is still a potential for abuse if it is injected, while Suboxone is buprenorphine and naloxone, which is an opioid antagonist. So if injected, Suboxone will actually cause significant withdrawal symptoms. Some epidemiology on opioid use and opioid use disorder in pregnant women. Between 1999 and 2014, the number of pregnant women with opioid use disorder at labor has more than quadrupled. According to some self-reported data in 2019, approximately 7% of pregnant women used prescription opioids. Of those women, 20% reported misusing those medications. Now, I live in New Jersey, and it was kind of hard to find hard data on opioid use in pregnant women. But as of 2018, the women that engaged in substance use, 69% of them reported using opioids in either the form of heroin or prescription medications. In terms of risk, maternal effects of substance use can include placenta insufficiency and abruption, preeclampsia, preterm rupture of membranes, and maternal death. That being said, many women who find out they are pregnant while they are using opioids are highly motivated to quit, although it is not advised that women detox from opioids completely while pregnant, as it is associated with a higher risk of relapse, which can lead to then overdose and death. Buprenorphine compared to methadone has comparable to better outcomes in pregnancy, but due to a lack of safety data on naloxone in pregnancy, if a woman is going to start medication-assisted treatment, Subutex is actually preferred over Suboxone. In terms of fetal risk, the major one is NAS, or neonatal abstinence syndrome, which can develop within 72 hours, most of the time for babies once they've been born. The severity is not related to maternal opioid dose. They can also have a significant number of congenital malformations, intrauterine growth restriction, preterm birth, and stillbirth. Some screening tools we have for substance abuse. One is 4Ps Plus, which is specifically looking at pregnant women. We also have the CRAFT score, which is used for slightly younger patients, 12 to 27, but is also been validated in pregnancy. Many women have a feeling of guilt when they find out that they are pregnant and have been using opioids. Opioid use can also cause amenorrhea, so many women might not even know that they are pregnant. Oftentimes they misinterpret symptoms such as nausea, vomiting, cramping as withdrawal symptoms, so you might not be seeing them until later in their pregnancy or when they are about ready to deliver. So some signs of withdrawal in pregnant women, you will see lethargy, dysphoria, drowsiness, constricted pupils, nausea, diarrhea, and hypotension. You might also just see them straight in active labor. So when taking care of a pregnant woman who also has been using opioids, it's important to remember that there is a strong correlation between undiagnosed psychiatric illness and substance abuse disorders. So screening for mood and anxiety disorders is incredibly important, and then adequately treating the depression and anxiety are crucial in supporting a woman's substance abuse recovery. And it's also important to screen for intimate partner violence among these patients. So in terms of prenatal care, besides the standard nutritional and lifestyle recommendations you're going to recommend to every pregnant woman, MAT can be a really important part of treatment, but should never replace individual or group therapy. Accurate pregnancy dating is also important given the risk for preterm birth and intrauterine growth restrictions. Prenatal labs should include screening for HIV, hepatitis B, hepatitis C, liver function, tuberculosis, and STIs, and then assessing any barriers to care, including things like transportation, childcare, food, shelter, that sort of stuff. And then for fetal assessment, you want to make sure that you have a targeted anatomy scan between 18 and 20 weeks. And then any further fetal surveillance really should be performed on an individual basis specific to your patient.